everybody. My name is Nina Vijayvergia. I am a GI medical oncologist at Fox Chase Cancer Center and an active participant in the North American Neuroendocrine Tumor Society, take care of NET patients. And today I have a privilege of speaking with Dr. James Yao, who does not need any introduction, as you all know. He has inspired many, including me, to be doing the research we're doing in neuroendocrine tumors and to take care of patients who are very special. So we are here today to speak a little bit about what's latest in neuroendocrine tumors and what we got from the recent annual American Society of Clinical Oncology meeting, as well as what's next in the area of neuroendocrine tumors. So before much ado, let's start. So thank you so much for joining us, Dr. Yao.
I'm so glad to join you.
Thank you. So, let's just dive in. The first thing, we wanted to touch base with you about that at the ASCO meeting this year, the final overall survival results of the NETTER-1 trial were presented by Dr. Strasberg. I wanted to see what you thought about the results and how does that affect your practice and does it change anything and what are your thoughts overall?
Yeah, the NETTER-1 study showed really strong efficacy in terms of progression-free survival, which has previously been reported. There was a trend toward a survival benefit at the interim analysis. What was presented at ASCO this year is the final survival analysis. It continues to show a trend to improve overall survival. The data doesn't cross the statistical significance boundary, but that's actually not that surprising. So because of the positive results at interim analysis, patients were able to, a lot of patients cross over, right? Mm-hmm. And when you have a crossover study, then really you're no longer measuring whether treatment is improved survival. You're measuring sequencing, whether double dose of octreotide followed by PRT is inferior to PRT upfront. Because fortunately our patients actually have fairly relatively longer survival, and most patients are actually probably able to receive PRT after they fail the initial treatment on the control arm. So then, you certainly can see some benefit from earlier treatment, but the magnitude of that benefit is probably beyond what we can, realistically detect in a 200 patient clinical trial. So that's kind of my thoughts on that particular analysis. It's also something we thought about and addressed a bit. Years back at the NCI clinical trial planning meeting that Dr. Koki and I hosted. And even then, we knew that if we really wanted to demonstrate overall survival benefit, the trials probably in thousands of patients, not hundreds. And we also probably could not really realistically allow for crossover. The longer survival is challenging for overall survival, but it's a good thing for our patients.
Absolutely, it's like it's a blessing in disguise in some way, right?
Yes.
Absolutely. So thank you. I think, and you point out to the next important part is it talks a little bit more about sequencing, not so much about the efficacy of the drug. And I'll just ask you a question. There was initially a lot of there's a lot of early phase data and indication coming up that maybe moving up lutetium dotatate earlier in the lines of therapy are more beneficial versus later. Do these results say the other way around for you at all or no?
I don't think these results really address the question either way. It's really not designed to answer a sequencing question. And my personal thoughts or opinion on sequencing is that I don't think we're ever going to get an answer there because, fortunately, the number of treatment options that are becoming available for neuroendocrine cancer patients is increasing. Mm-hmm. And that means, looking at all the different possible sequences and which one leads to the longest overall survival becomes an almost insurmountable task. The number of arms and the length of follow-up, size of those studies, I think we're much better off investing our time and energy for more treatments than figuring out how to sequence existing treatments in many ways.
That's a very important point, and something that's definitely makes so much sense. Like if you start looking at sequencing, the permutations and combinations that come out of it are sort of so mind-boggling that for young researchers like us, when we think of studies, one question comes as sequencing, and then we're like, I just don't know what to do here.
Yeah. And the other, the fun saying is, if you actually try to attempt to do that study, by the time you finish the study, probably a newer drug would have been introduced and your study would no longer be relevant.
I know, that's a great point. I know, thank you. So the next question I had is, because I know you're such a statistical guru, and for all of us, the study, the long-term survivors of NETTER-1, they talked about the crossover adjustment specific sensitivity analysis, or yes, that's probably what it was called, in which I think they somehow accounted for the crossover, but it's still, so I don't know what, how we don't know much about that analysis, but how does that affect your opinions too?
Yeah, in some ways, the only analysis that really matters is the primary endpoint followed by hierarchical testing in terms of what else you plan to put into the analysis plan. So anything beyond that, in my mind, is exploratory. The two typical methods folks have typically used to try to adjust for the effect of crossover is, one is rank preserving structure failure time, and the second is is essentially then rank preserving structure failure time is really emphasizing the first part of the study, where before crossover and essentially what's happening to those patients who doesn't cross over but have an event. What it does is try to adjust for what would happen in the control arm if those patients didn't cross over. Mm-hmm. So it doesn't change the outcome in the experimental arm, but it makes the adjusted control arm outcome. The challenge is, one is that if you don't have enough events in the early part of the study, it can be very difficult to do that analysis. The second thing is, when you do that, your confidence interval gets wider and wider. It usually does not help you to cross the significance threshold. That's probably the most common method. People try to look for that. I think in this study, the company and the authors also looked at restricted mean survival time. Mm-hmm. Essentially saying, I'm going to cut off the data after a certain period of time, right? But I would say that that has to be interpreted with a great deal of caution, because doing that may help with some things, but may hurt other things, like long-term toxicity. Mm-hmm. What if your drug has longer-term risks of developing leukemia or hematologic disorders or secondary malignancies or kidney problems? When you cut off follow-up, restricted mean survival time, you lose what happens at the tail end.
Right. Great point. Thank you. Thank you so much for mentioning it. And then that's a good segue into the next part. So in the study, the rate, and even with longer term follow-up of 5 years after the last patient was randomized, the rate of MDS leukemia was still at 1.8%. No further cases happened. And also, the other thing they pointed out was the rate of grade 1 to 2 nephrotoxicity was about 40%, and grade 3 was 5.6%, despite the use of, protective amino acid solutions. So just wanted to see what your thoughts were and how in your practice, have you felt it to be similar? Like, what are your thoughts about that?
Yeah, I think that's a great discussion, because, with lower grade toxicity, like grade 1, 2 toxicity, often if you're just treating patient in your practice, you won't notice them because this is a minor bump in creatinine, and you never know whether it's due to the drug or just from aging or other factors playing a role. It's really useful to look at this, large randomized control trial where you can compare it to the control arm and understand exactly what the effect is. Because these are a little bit later toxicities, I don't think you can really try to make much in the way of treatment decision while the patient's on treatment. Meaning, while they're getting the treatment, you may not be seeing those creatinine elevations. It's not until the treatment's done and once the radiation is given, you can't back it out. So I don't think it really affects the treatment decision that much. And that's also why it's so useful to look at the outcomes such as the overall survival, although it did not show a statistically significant benefit, but there is just in terms of point estimate, there is a suggestion that it may be a benefit. Certainly no suggestion is harming. So I don't think it really affects my decision in treating the patient, with maybe the exception of just having caution in patients who are relatively younger and may need treatment for a long period of time. And if their kidney functions a little borderline, then you may have to think about when you want to use the PRT.
Makes sense. So I think overall we all, I don't know, I still feel that lutetium dotatate is currently the holy grail for treatment for neuroendocrine tumors. What are your thoughts? Do you think it's still one of the most strongest stuff we've got out there?
Yeah, no, I think it's a highly effective therapy. The hazard ratio on the PFS of speak for itself, almost 80% reduction in risk of progression, and it's generally well tolerated for the patients. So it's definitely something that's going to be our armamentarium for treatment of patients with neuroendocrine tumors.
Thank you. That's true. So from there, let's move on to what are you excited about? Like what's coming next that you think is going to be the next thing we talk about at the next time we meet?
Yeah, I think, there's in terms of what's coming up next in the shorter time frame, I think it's going to be talking about oral agents targeting somatostatin receptor, and also VEGF inhibitors for extrapancreatic neuroendocrine tumor. So these are where drugs are already entering the clinic in some cases in late stage development. So maybe starting with VEGF inhibitor, surufatinib has been presented a couple of times now, both in pancreatic NET and extrapancreatic NET. And I think it's especially important in extrapancreatic NET, because although we have PRT, we still have relatively few options. The existing treatment like PRT, everolimus, and somatostatin analog work great, but almost all of our patients need something else at some point in their journey. And there's been already some data from other trials suggesting VEGF inhibitor may be important, but the surufatinib brings a positive phase 3 trial. As I understand, they have already completed rolling submission to the FDA. So, and that may bring an additional treatment option for us. In pancreatic NET, I think it's also going to have an important role. At least in my experience, it's a little bit of a cleaner VEGF inhibitor, and maybe better tolerated than sunitinib. So so that you may be of importance there as well. And for sure, in lung neuroendocrine tumor, where right now we only have one approved agent, we definitely need more. Thanks. Yeah, we definitely need more. So getting VEGF inhibitor into other parts and neuroendocrine tumor beyond pancreas will be great. On the oral agents targeting somatostatin receptor, we have a compound from chiasma, which is oral octreotide essentially, and then we have another company developing a small molecule that's targeting the somatostatin receptor, and I think both of these will be important to watch for. I think it will be great for option for our patient in terms of quality of life, being able to take an oral agent. I certainly had my patients struggle. It's summertime, they want to go on vacation, but they don't want to have to go establish care with another oncologist in another state just for a month or two while so they can get their shot. So having an oral option may be a great thing for our patients as well.
Absolutely. With all the site of care restrictions and stuff, the insurances are introducing, it definitely will be something we will all welcome.
Yeah. I think beyond that, I think we really need to explore new pathways and new areas for NET. If one were to go beyond somatostatin receptor, mTOR, and VEGF, where do we go next? I think here's an area we do actually need more translational and basic research that needs to happen. I think the biggest challenge continues to be the challenge of modeling neuroendocrine tumors in the lab. Because if you really have a representative model for neuroendocrine tumor, like in the human situation, you'll have a doubling time of like 12 to 18 months. Fundamentally, that just doesn't work in animal models or in cell lines. So we're looking at ways to see how we can overcome that. So looking at ways we can switch the kind of growth on and off, so that you can actually get the tumor to a reasonable size, and then have it revert back to the normal human biology for targeting these tumors. I think we're going to need more of that, so we can test more pathways and more agents in neuroendocrine tumors.
Sounds good. Thank you. So very exciting. Yes, I think the future is bright and that's why we're all in it. And so thank you so much. Thank you everyone for listening to us. This was very inspirational and also very educational. So I hope you all enjoyed. Thank you and have a good day.
Thank you, Pam.